Good morning, everyone. Thank you for being here for T-Task's 12 Sector Collaboration Series. Today, we're focusing on the health sector. I just want to introduce our team. I am Jennifer Jacobson, and with me here today, we have Lisa Mason, Ken Ploward, Shay Montemuro, Mark Nickel will be joining. And
I think you're freezing, Jen. Or is that me? I'm sorry.
I am.
It's her. She froze.
I did. Can you hear me now? Can everyone hear me now? So sorry. Can you guys hear me now? Can you hear me now? I'm so sorry. Let's try that one more time. Welcome to today's 12 sector series, and we'll focus on the health sector. With T-Task, I am Jen Jacobson, and I've got other T-Task members on here today: Mark Nickel, Ken Ploward, Lisa Mason, Shay Montemuro, and David Reyes. A special welcome to our two guest speakers here with us today, who will be sharing later on in our meeting: Carolyn Wilson and Gina D'Angelo. Thank you for being here today. Just a few housekeeping notes before we get started. If everyone could please keep themselves on mute, that would be helpful, unless you're going to be asking a question or sharing. Also, we are recording today's session, so we can post that on our YouTube channel along with our other 12 sector series, so just be aware of that. Also, we will be stopping along the way for Q&A, so just make notes of any questions you may have as we proceed, and we will call on you at certain times in the presentation. And finally, you will get all of the materials from today. No need to try to copy down all the text from the slides. We will definitely send you everything after today's presentation, so you will have all of those materials. So I'm going to go ahead and share my screen, and we're going to get started. All right, everyone can see the presentation, I hope. Yes? Great. So just a brief overview of today's session. We're going to be walking you through the health sector within the Strategic Prevention Framework model. You're going to gain some knowledge of the different levels of sector involvement. We're going to start to introduce some understanding of social determinants of health and health disparities in Connecticut. We're going to learn from some shared experience from our guest speakers and from each other, hopefully, and identify some barriers and challenges to engaging with the health sector. So just a brief overview of the Strategic Prevention Framework, as we call SPF. I'm sure many of you are familiar with this, but for those who may be joining us who are not so familiar, it's a 5-step model with 2 guiding principles that offers prevention planners a comprehensive approach to understanding and addressing substance misuse and related behavioral health issues facing their states and their communities. So just quickly, the 5 steps include assessment, where you're really asking what is the problem. Capacity is what do you have to work with in assessing your resources and readiness. Planning, what should you do and how to do it. Implementation is where you're really delivering on a plan. Evaluation is you're examining your practices, your processes, and your outcomes, asking yourself, are we succeeding and where do we need to do some more work? And undergirding those 5 steps, you've got cultural competency and sustainability. So as we get into the health sector, it's technically defined as health professionals and organizations. So some examples we provide for you. Again, there's going to be a lot of text on these slides. I'm not going to read them all to you. No need to take notes, but just to give you an idea, some examples of health sector professionals, representatives would be any medical professionals such as doctors and nurses, health departments, local, state, regional, health organizations such as hospitals, treatment centers, and prevention organizations, and including our mental health professionals here as well. So our social workers and psychologists, and pharmacists as some examples. So just to get a brief assessment really quickly on how people are engaging with the health sector right now with where you work, we're going to do a quick poll, which is which health sector representatives does your organization or your coalition currently collaborate with? If you could go ahead and just answer that poll. Okay. Great. Can everyone see those results? Great, look, mental health professionals, 100%. So it looks like we've got some nice engagement with the health sector already. Thank you for sharing. Engagement opportunities, just a brief overview. And when we're working at the health sector, we're looking at the health sector is just elevating the health professionals' voice around prevention. I mean, health professionals are engaged in prevention work every day, so we think of them in that way. Engaging their participation in coalition activities, in hosting and participating in your prevention events. Play a key role, obviously, in all of our communities in providing services and information for our priority populations, and just partnering with the coalition on a series of activities and strategies. So after our second poll, just another needs assessment to see where you're already engagement is which of the following activities do health professionals in your community participate in? Just a reminder, if everyone could mute if you're not on mute now, thank you. Okay. So for everyone on the call, this gives you an idea of how organizations and coalitions are currently engaging. So it looks like a solid amount, over 50% for most areas, except for social norms campaigns messaging. Okay, good to know. Thank you. So we're just going to briefly walk through each of those steps with the SPF and the health sector. So here we're talking about our needs assessment. We're really looking at data collection, and when we're talking about health data, there are a number of tools and resources available where you can find health data in your community, region, or state, including things like rate and incidence of substance use and mental health related visits to medical professionals, looking at your local and regional state reports, overdose reports, treatment services inventory, looking at your and hosting focus groups or key informant interviews where you think you might have some gaps, and providing brief screening and intervention opportunities, and just a community scan of the service types that are available and not available in your area. So obviously in needs assessment, we then use our data to identify our priority substances and populations and our associated risk factors and protective factors. We then, of course, use that data to tailor our programs and activities to increase the capacity of the coalition going forward. Second step is capacity, is when you're really looking at all of you, your resources and your readiness, identifying your existing and new resources that you may have that strengthen the coalition and the community's readiness to implement prevention work. So we provide for you here just a number of activities that we see across our state and our coalitions that help to engage the health sector. So providing meetings and event times where they can join, seeking out their input on policies, looking to partner with them on community events, sharing your data. So a lot of our coalitions and organizations do surveys or have data available, and lending that information to our health sector representatives, and vice versa, seeking out their input on information that they may hold on emerging trends or what they're seeing on their everyday basis. Planning. So once you're through with needs assessment and capacity, we're looking at our planning, and that is identifying our priority prevention areas and our risk factors. And you're creating a plan to identify the strategies and activities that address those specific needs in your community. So we tend to think of these strategies as best fit. They address the particular substance and risk factors that will work where you are. In this phase, you're really identifying those measurable goals and objectives and how you're going to address them, and thinking forward to the evaluation phase that will look at, did we achieve some of those measurable goals and objectives that you're setting during the planning phase. In planning, we're also being mindful of cultural competency and looking at our subgroup populations. We give you a couple of examples here, such as LGBTQ+, persons of colors, athletes, faith-based youth groups, special education, those who might be on an IEP, court diversion and truancy cases. So just keeping in mindful are our subgroup populations. And again, more examples here of what we see of how you can incorporate the health sector in some of your planning. Implementation, always my favorite part when I was a coordinator, when you're out there in the community delivering those strategies. So this is once you have your priority areas are determined, you've got your plan, and you're engaging in those strategies out in your community. So we provide for you, here's several ideas around implementation with the health sector. What kind of training and supports can you provide to the health sector on prevention strategies and vice versa, them to you as a coalition? Inviting healthcare sector representatives to be guest speakers at your coalition or at community-wide presentations, asking them about the benefits of being in the coalition and any educational materials that they may have and be able to share with you. We've seen social marketing. So a lot of coalitions do social norms campaigns, and that came in earlier as one of the lower areas. So that might be an area where you can say, how can we really build in some health messaging using health data into our social norms campaigns and elevate that information that we already have. So now really, we're going to go into a breakout room. And Ken's going to put us in breakout rooms for about 10 minutes. And what I would like for you guys to discuss in our breakout rooms, and that we will come back and share together, is during COVID, what lessons can be learned in how your community or your organization or your coalition that you're representing here today worked with health professionals and organizations and how they responded to support youth in your community during COVID. So I know everyone really rallied, first responders, everyone came together. So we're really interested in finding out, what did your community do, your organization do during this time to protect youth at that time? So there's no right or wrong answer, and then we'll come back and share. So Ken, if you want to go ahead and launch some breakout rooms, we'll allow like a 10-minute conversation, and then we'll come back and share a little bit.
All right, I'm off mute finally. Do you want to stop screen sharing, Jen?
Sure.
This way, yeah, we have a little bit better view. Nice. So I just want to check on the rooms real quick.
Is it just the three of us in this room? Are we in?
Yep, I did 4 rooms because there were 16 of us in here. So yep, it looks like it's just the 3 of us in our room, which may mean that somebody didn't accept the invitation to join the room.
Okay, all right. Hi, Joanna, are you there? Joanna?
Okay, so it says that she has not joined.
Oh, okay. All right. So do we just want to talk
Okay.
about our 2 communities really quickly?
Yeah.
So what happened in your community?
Sorry, I'm just monitoring a few things. So I think that, sorry, I'm reading the question again too. I think it was helpful to hear from first responders coming out to community events, and in talking, not just to youth, but also to more like the community at large, especially when they would talk about Narcan and the opioid crisis being super stigmatized, in many communities. But I think the way that those particular health professionals came out to do community outreach definitely helped raising awareness around opioid related issues in our community of West Hartford when I was coordinator.
Nice. So one thing we did in Fairfield was, I was still the coordinator at that time, and we worked with our evaluator to do a very informal parent survey and a very informal student survey, just using SurveyMonkey, just to gauge how everyone was doing, what changed in their life, what was working well, being in school, being out of school, what were some economic challenges, just to get a pulse on the community from those. It was obviously very informal, not a lot of time to launch it. So, it wasn't a huge response rate, but we gave us a good idea on what were some of the challenges, being able to go outside, how they were coping, resources, using friends, using social media, using technology. This is way back when we first went into lockdown. Youth were, struggling with being out of school a little bit, missing their friends, definitely missed participating in all of their typical activities like sports and clubs, just that missing that social interaction. We also learned that, adults were reporting more substance use, particularly around alcohol use. So they were candid in that, yes, that was one of the things that was happening, that's remember when we started going direct to consumer in Connecticut, where you could get those grab and goes, and restaurants were allowed to sell to people to go. So, and then liquor stores were doing direct to consumer more. So it really gave us a good lay in the land that we as a coalition could respond to when we were looking for interventions and providing greater supports at that time. Of course, the typical health things were, running those testing clinics. And I think all of our health departments just were working almost around the clock with contact tracing and really trying to keep everyone safe and as healthy as possible. So those are some of the areas that I felt that we really upped our game in terms of responding to what was happening to youth in our area at the time.
Yeah, and I think too, at least in West Hartford too, at the teen center that's run by the Bridge Youth and Family Service Center, they really did a good job doing like a lot of transitioning to online events and stuff like that, like watch parties, and a lot more routine check-ins with a lot of the folks that were, in the teen center. And, it definitely helped, talking to a lot of the teens. It was definitely something that they looked, very much forward to.
Yeah, I think a lot of the coalitions really quickly responded in getting those conferencing materials so that they quickly moved to online meetings.
Yep.
And adjusted, and actually were able to not only keep but improve their attendance rates by doing that. And some of them now today are still doing it this way, even though they could possibly be meeting in person, just because that attendance rate did seem to tick up. So there were definitely some silver linings around what happened and lessons learned going forward, I would say.
Yep.
Okay.
So we got like, I didn't set the timer, but I've been watching it. So we have like 2.5 more minutes before we're at our 10-minute mark.
Okay. So when we go back out, I'll just call on a couple people, Romeo maybe, and Lisa or Mallory. Because we have one more breakout room, so I want to keep a couple names.
Yep.
Okay, great. So great, thank you. This worked out well. Yeah,
no, that was I was a little nervous at the beginning. I'm glad the bandwidth for everybody is back in action now.
Yeah, I just don't know what happened to me there for a second.
Yeah, no, it was
I was like, I'm glad I sent you the presentation.
Yeah, I was like, I turned my screen off. I'm pulling it up. I'm like, I'm ready to go. It's all right. And then I was so happy to see you come back.
All right, so I'll see you if you want to. We can go back out if you want.
Yeah, I'm gonna actually, because I think there's a minute delay too from when I end the room. So I'm gonna close rooms in just a moment.
Okay, great.
You can head back to the main room.
I don't know how to do that. It just says close all rooms.
Okay, so I'm gonna close the rooms right now.
Okay.
Okay, so we have a minute now and we'll automatically all go back to the main room.
Okay. All right, everyone should be coming back in out of their breakout rooms. Ken, is everybody back in?
We still have a few more people, maybe 6 or 7 we're waiting on. So probably like 30 more seconds, everybody will be back in here.
Okay. And let's see. I'm going to call on Mallory. Would you mind, when everyone comes back in, would you mind sharing a little bit about what you talked about in your breakout room? Is she there?
Sure. I started 2 weeks ago, so I am kind of fresh and just trying to take in what others have talked about and mentioned. I am the new program coordinator in Ellington, so yeah, haven't done too much other than just kind of brainstorming and just taking in and observing as much as I possibly can from everyone. So
what were some ideas that came out in your breakout session about how people responded? Did you get to jot down anything of note?
Yeah, so Holly was mentioning really the connection to mental health and just working within that sector, and the challenges that are obviously in place because of COVID. But yeah, and then Lisa is more on the behavioral health side. So yeah, it was good just to talk, and I think talk through maybe some of those barriers or challenges that may come up. I know I had mentioned for Ellington, it's a small town in the sense that there's, one pediatrician on staff and there's one urgent care, but other than that, as far as local, it's looking more like we would have to talk with like the health department that's out of the North District Health Department, I'm sure, North Central District Health Department, but yeah.
Good. Thank you for sharing. So yeah, in my group, we talked about how our first responders just really stepped up. Our coalitions were able to really quickly transition to online programming, really tried to connect with youth in their community, since a lot of them were not in school at that time. I know in my area, we did a brief parent survey and student survey just to get a gauge on how everyone was doing, what they were struggling with. It seemed like social media and technology really helped our youth and our families stay connected as best that they could at that time. Did report some increase in substance use at that time as well. And remember, restaurants, and we were doing direct consumer, and we had a lot of that grab and go. So definitely some silver linings that came out of this going forward, I felt like. But if anyone else would like to share, otherwise we will keep going on. So just hopefully that you guys were able to really share what happened in your community and the resources that were made available, and just how quickly everyone really just rallied around our youth and to provide as best as we could at that time. So Shay, I'm not sure if we have any questions at this point. I'll just take a brief break in the chat box.
Nope, no questions right now.
Okay, thank you. So in our final step, we're looking at evaluation, and you're collecting data on your impact to share your successes. There's process data, which we define as ensures the program was implemented as it was intended, and outcome data helps identify if the selected strategies that you chose in earlier steps contributing to meaningful changes in your risk factors and substance use. And some ideas here are just examining those health data sources that we talked about earlier in needs assessment and recording your changes over time. Always like to recommend that when you do any evaluation that you create a community presentation on your results and provide several opportunities, whether it be PTAs or BOEs or town bodies or just for your coalition itself to understand where you were and where you are now in terms of evaluation, and then looking forward what you might need to do. Just briefly touching on cultural competency, technical definition, the ability of an organization or individual to understand and interact effectively with people who have different values, lifestyles, and traditions based on their distinctive heritage and social relationships. And this comes from SAMHSA. So just describing how the health sector professionals contribute to the role of cultural competency within your organization. Always in this area, we're looking to dive deeper into our data to look for hidden or underserved populations. and just seek out new information from those populations that may be missing. Also looking at our demographics over time in our communities as those change so that we're keeping up with those changes over time, holding some focus groups with different organizations such as doctors and mental health professionals, and just making sure the materials that we're providing are culturally competent and we're watching the language that we're using. Sustainability, the process of building an adaptive and effective system that achieves and maintains desired long-term results. Sustainability is really thought about in every step. It's not something we're looking to do towards the end, but looking in at every step of the process, how we can sustain our efforts and our prevention efforts. So looking at the health sector representatives, how can they contribute to sustaining your organization and your prevention efforts? Working towards our partners, owning our prevention initiatives, figuring out what information or resources do they need from you in order to help sustain your organization. And we'll be giving you a chart later on in terms of how the SPF contributes to sustainability as well as a resource later on. Kind of transitioning now into health disparities and social determinants of health. And I hope this will be helpful for everyone. So in January of 2020, Connecticut did release a report, which I do provide you the source link in your presentation. So when you get this, you will be able to go directly to the report. Just giving you some of the images from the findings here in Connecticut on health disparities. And this report was done by the Connecticut Health Foundation. So when we look at this, we can see that they've identified several areas of health disparities in Connecticut, from diabetes, to gaps in access just to get healthcare, infant mortality, asthma rates, and disparities in health insurance coverage here in Connecticut. So when you have time to go into the report, you'll be able to get some more data on that, but we're going to look at this a little bit further. So what did the report kind of find? What are the big takeaways from what they found? So factors that contributed to health disparities here in our state were differences in health insurance coverage, access to healthcare, being able to just get to where the right providers that you need, and social factors. So things like food security, transportation, neighborhood safety, housing, safe and secure housing, and disparate treatment and discrimination. And I know I'm going to call on one of my colleagues right now. Lisa, I know you have some thoughts on some of these factors.
Sure.
Do you want to make a comment here?
Sure. One of the things that I learned recently when we're talking about differences in health insurance coverage, I learned at a health disparities workshop that one of the PTTCs conducted, the Prevention Technology Transfer Center. They talked about how having health insurance becomes a protective factor against substance misuse, because the potential for screenings for substance misuse is there. So just that becomes a protective factor. And then when we're talking to, access to healthcare, what are some of the disparities that can come in? Do I have insurance? Can I pay the co-pays, or for people with high deductibles, can I pay those? Transportation to healthcare, as well as childcare, especially like if you're looking for treatment around substance misuse. Childcare becomes a real issue for moms, especially young moms. In terms of social factors, when we're looking at disparate treatment and discrimination, we can consider gender, LGBT, Q status, racial, ethnic, language. Those are some of the things that we can look at. And then did you? Yep.
Thank you, Lisa. That provides a nice lens on that. So what did the report come in terms of recommendations for Connecticut to address some of our health disparities here? So number one was improved data collection to ensure that health outcomes are measured and tracked by race and ethnicity. And like Lisa said, some of those other subgroup populations as well would be helpful, and act on the findings. So focus on getting people more healthcare coverage. Support community health workers, make sure we're providing that workforce development, that professional development, the awareness and the education and training, whose services have been shown to reduce those disparities, and promote clinical practice guidelines and evidence-based treatments. So because this is such an important part of today's presentation, we really wanted to provide an opportunity to go into a breakout room and talk about health disparities in the areas where you live or where you work or both. And this can be anything from just things that you've anecdotally observed or that you've really done a lot of data collection and you know the disparities in your community. So there's no right or wrong answer here. Just want to provide a space for those to go into a breakout room and look at who, what, where, why, just what are some of our thoughts on some of these things where we work or live or play, and then come back and share some of our own experiences with health disparities in Connecticut. So Ken, I'm going to stop screen share if you want to put everyone into a breakout room. And again, we'll go in for about 10 minutes or so and then come back for a brief sharing. Okay, are we in breakout rooms?
We are.
Is Joanna still not in one?
She, it says not joined, which I believe she just needs to accept that like invite to join.
Okay.
But
we can talk about our communities while we're all here.
yes, we can.
What is your evidence?
So I don't know, the first thing that really came to mind, I'm just thinking back to when I was a coordinator because I was much more involved in the community. So like we had two high schools, right? In West Hartford, you had your, Conard and Hall. And one of those schools gets kind of like the rap as being like the bad high school, the bad side of town. They have like the higher use, although you find that the usage rates are very much the same between schools when you actually like look at the data. So they tend to get like pinned on this as being like the the troublesome part of town. But what we really witnessed as coordinators, or as a coordinator, was trying to get transportation for kids from one of those schools to the teen center after school to provide them with a safe, space, drug-free environment. And we even had students go before, the town council in pleading their case for this. And apparently this was going on even before I had been coordinator for years. And for some reason, we never kind of won that battle of being able to get transportation for those students. So, I mean, that instantly came to mind when you were talking about all of that stuff. And I think that's what, we were trying to do, right, is find that drug-free space, provide them transportation so they weren't, walking long distances, or at night, I mean, even, having girls walk home in the dark who are, in high school just seemed kind of, not right. So that made me think of the disparities that were going on in that community.
Yeah, so it sounds like, if I'm going to summarize, providing equitable access.
Yes, and access, exactly.
To the opportunities
for drug-free environments and
that
spaces.
Some people had greater access to.
Yes.
Some of those that others did not.
Yep.
Simply by virtue of the transportation access that they didn't have.
Yep.
So even
their geography within that
right.
town. Yeah.
So even when you are offering alternative events or offering opportunities, making sure that everyone can actually benefit from those. So it's not enough to just offer them. We have to make sure that the access to them is
right. It's not a one size fits all solution that you can use.
Right. In our area, we've been looking at subgroup populations a lot more. Starting in 2019, looking at when we were doing search surveys, I noticed a lot of gender variances in our, on the search survey when the assets, the developmental assets.
Yeah.
That we were seeing a lot less of those developmental assets in our boys than our girls. So our boys were telling us that they were struggling more in terms of achieving those developmental assets, so higher risk factors. And now we're even breaking that down even further into students who are on an IEP with higher rates of substance use, and also LGBTQ plus subgroup populations as well. So we have really begun to look at really deep down into the data, and in order to be able to target programming and messaging to that really speaks to those populations. So those are some of the disparities that we've known. So assets and subgroup, higher risk factors and higher usage rates.
Yep.
How are we going to address that, right, going forward? Hi, Charity.
Hi.
Hi, thanks for joining.
Yeah, sorry I'm late. I had an.
Oh, that's okay. We're just talking about observed health disparities in our communities. I think we have a couple minutes left, but I'm Jen. Hi, nice to meet you. I was talking about looking at our data, our survey data, really looking at subgroup population differences by gender. Our boys were telling us that they weren't reaching as much developmental assets as our girls. Also looking at IEP disparities and LGBTQ. So just really digging deep into our data in terms of where we see higher risk factors and where we see higher substance use rates. And now kind of thinking about, well, how do we reach those groups in a better way to address those needs? And Ken was sharing about even when a community may have opportunities for youth, is it equitably accessible? Can everyone get there? Can everyone make use of those? And how do we make sure that we're providing those, not only the opportunity, but the access? So I don't know if you have any thoughts about what's going on in your area.
Yeah, that's one of the things that I'm trying to figure out is how we can get a clearer picture from our data with some of those different groups, because we don't have that specific level of data. We're looking at LGBTQ or maybe kids on IEPs. We just have like gender and ethnicity at this point in our data. And so that's something like we're working with CREC does our local surveys for the community and for youth. And so we're hoping that we can kind of expand a little bit before we administer again in January or February with our youth and community survey to get more information.
Great. Any observations from what you do have in terms of any disparities that you've noticed, right? Either race or gender?
No, not really. I mean, I don't know where you guys are located. Colchester is like 95% white.
Gotcha.
And it's, I would say, an upper middle class, like the median income here is around 100,000. So most of the kids here can access services, and we just, I don't think we do a great job of capturing those that are not in that population of white and upper middle class. But at the same time, like, because there's so few outside that bubble that like we risk,
Yes.
Yeah.
I hear what you're saying. So the challenge is being able to, because it's a small group population, getting your arms around that data because of, I'm sure, privacy issues or identification and things like that.
Yeah.
And so maybe bringing people to the table from that community, like key informant interviews maybe, or some focus groups or something like that, maybe is less formal.
Yeah. And we are actually getting ready to do the developmental assets profile in our middle school and high school. And we are going to use the expanded gender on that. So I think hopefully we'll get a little more information from that.
Great. Ken, how are we doing?
Good. I have 2 more minutes written down. I thought I set it for an automatic 10 minutes, but I'm just going to stop it at 10:42.
Okay, and then that's a minute.
It's like a minute and a half. Yeah.
To transition.
Yep.
Okay, great. So we'll give everyone a little bit more time, but no. So if we share, Ken, if you want to, I don't know if Charity or Ken wants to share because I did last time, but just that equitable access, I think, in subgroup population identification, and just the challenges and sometimes in being able to get the information that you might need. That would kind of sum us up, I'd say, right?
Yeah. Sorry, I'm just writing this down now too. Equitable access, identification of subgroups, priority subgroups.
Mm-hmm. And what did I say? Equitable access to opportunities.
And maybe data collection challenges.
Yes. Especially when you're looking at possibly a small group. And
Yep.
how can that be overcome somehow in terms of a barrier?
Okay. All right, I am going to end the rooms right now.
All right, thanks.
So we'll have 60 seconds.
Okay. Looks like we are on track in our timing right so far.
Yes, we're looking good.
Just let me know, Ken, when everyone's back in.
Okay.
Romeo.
Waiting on about 6 people.
There we go. All right, looks like everyone's back in. If I could just remind everyone, if you're not talking to, please mute. And I am going to just pick a name out of a hat here. Sarah Duflameri, are you there?
Hi.
Hi. You want to share what you guys talked about or some of your observations?
Sure. We had we all work with different in different work and in different populations. So we had some different things to talk about. One was just kind of keeping track of the data that we can find so that we can kind of report back on these disparities. There were some concerns over like fear with COVID possibly being a factor in going out or in going into healthcare settings, particularly for those who are in vulnerable populations. We also had, so I work with youth, which means that I have a lot of kids who can be like on Husky or on other kinds of insurance, but their parents may not be. Or we have kids who don't trust some of our referrals, or are not comfortable. They may have had traumatic or otherwise bad experiences in the past with healthcare or mental health care. And we have to spend time kind of building up that relationship with them before they're able to be referred to a service. And that is not always appreciated or like acknowledged when it comes to grant funding or other things. The relationship building part as opposed to just referring to services. So we had kind of different experiences and different outlooks, but definitely room to grow with the healthcare field.
Great. Thanks, Sarah, for sharing. Ken, did you want to report on our little group?
Yeah, we had our group had kind of 3 main ideas that came out of our discussion. And the first was, in your community, there may be a lot of resources for folks, but the idea that is there equitable access to those resources. And then the second being the identification of priority substances, priority subgroups from school surveys or community surveys. And things like that. And also in that kind of same vein, the challenges that may present themselves when you are collecting data and there may be within a small group of people where, identification, privacy may be some concerns. And, what are some of the best practices around, collecting those data, maybe go for the qualitative data gathering approach, that might be some key informant interviews rather than just some survey data. So those were some of the things we discussed.
All right, great. Thanks so much, guys. If anyone else wants to share, feel free to unmute if you're not. Otherwise, we will continue on. Did anyone else want to unmute or share?
I don't know if Holly or Carolyn want to speak from our group.
Sure, I'll weigh in really quickly. We talked a lot about, and two things that Vernon and Groton have in common, as we learn from talking, is income disparities and how different sections of town can have different experiences based on who's living there. And in my case, in Groton, it can affect schools, and Groton has had to go intra-district magnet to try and even out some of those imbalances, or we were going to lose school funding because it really didn't look good what was happening. And it wasn't necessarily purposeful, but it happened. So we've had to grapple with that a little bit. Talked a little bit about military communities and Hawaii, and yeah, it's interesting. Even if you live in a town where you don't think that there's a lot of going on in terms of diversity or disparities, all you have to do is unturn a couple of rocks to find what's going on. So
Awesome. Thanks so much, Carolyn. All right, I'll go back to our presentation. So we're just going to introduce the idea. I'm sure many of you have heard of social determinants of health, but we wanted to introduce this to you guys today in this presentation. I feel like this could be its own training all in of itself, but we definitely wanted to give you a broad overview of social determinants of health. And this information comes directly from Healthy People 2030, which is a report directly from the US Department of Health and Human Services. So defined as the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. Social determinants of health can be grouped into 5 main domains, and we provide you with those 5 main domains here, from economic stability, education access and quality, healthcare access and quality, neighborhood and built environment, and social and community context. So when you go, you get this presentation. These are live links. You will be able to click on each one of these 5 domains, be taken right to this US Department of Health and Human Services report on social determinants of health in order to get more information on each of these 5 domains, and actually be able to get some evidence-based strategies around the areas within these buckets. So not going into that all today here on this presentation, but we definitely wanted to make sure that you all had access to the information and to learn more if you'd like to, or to actually start thinking about some of the evidence-based strategies that might work in your communities around some of these areas as you work to identify some of those disparities going forward. And I'm going to stop screen share, and Ken is going to just give you an idea of what one of these looks like when you will click on it, so you have an idea of what it looks like and how to navigate around a little bit, because we wanted to make sure you know where you would be going when you click on it. Go ahead, Ken.
Sorry, I was trying to find my unmute button. Sorry. So yes, so that, like Jen said, this will, when you click on the economic stability box in her presentation, it will lead you directly, to this landing page where you get a little bit of background in some statistics about in the United States economic stability, and then, like she said, you can go into some of these objectives here. So, Jen, was there anything else that you would like to add about?
No, I just wanted everyone to know what they were going to be looking at. At the top there on the left as well, if you scroll all the way up, Ken, you'll see the evidence-based resources. So each one of those 5 buckets and domains, as we call them, will provide you to a place where you can start learning about evidence-based resources for each of these disparities. So I hope it'll be a really helpful tool as we continue on with these conversations. Thanks, Ken. Thank you very much. Briefly, just going into the 5 domains a little bit further so that you have an idea of what do these things look like, what do they mean, what are the indicators around them. So you can read this on your own when you have a little bit more time, but just a brief overview. Economic stability would include things like housing and employment and nutrition, healthcare, poverty. Education is obviously, I think, a little bit self-explanatory, but just providing quality education opportunities for children and teens, disability resources, graduation rates, post-secondary opportunities, school readiness. Healthcare looks at things like being able to have access to the services that you need, health insurance coverage, preventative health visits, screenings for substance use and mental health, reproductive health, and prescription medication. Neighborhood and built environment goes into things like violence reduction in communities, having safe air and water, pollution reduction efforts. Workplace safety falls in here as well, and creating some healthy environments on neighborhoods such as pedestrian and bicycle friendly neighborhoods. Social and community context indicators include things like social supports, such as having like a trusted adults in your family, positive family communication, reducing stigma, and increasing our health literacy, food insecurity, addressing that, and discrimination or bullying. So just giving you an idea of what kind of falls into each of those 5 domains. If you have any questions, feel free to put them in the chat box. Otherwise, we will go on to our next segment. Shay, do we have anything in the chat box right now?
Oh, we're good.
Okay, great. So now we're going to come to our favorite part, our coalition shared experience, and our speakers that are going to speak to their experience in working with the health sector. So first, we're going to go to Carolyn Wilson. She is coordinator at the Ledgelight Health District. So thank you so much. I'm going to stop screen share, and Carolyn, it's off to you.
Hi, everybody. I'm going to share my screen. All right. So hi, everybody. I know some of you very well. Some of you I don't really know at all. So I'm Carolyn Wilson. I work with Ledgelight Health District, and I coordinate GASP down in Groton. And that's our social media handle. Up until yesterday, things were going really great there. So anyway, having a lot of fun on there. I just want to thank TTASC for inviting me to come speak today about being part of the health sector, but also needing the health sector and being recruited as somebody from the health sector. So this is actually a great topic for me to be talking on, and thanks so much for having me. So I wanted to start today with kind of a little bit of a story about me and how I got started in prevention, which kind of has nothing to do with what we're talking about, but I wanted to add some context to the whole picture of the health sector and how I became a part of it and how I recruit from it, et cetera. So I started working at Ledgelight Health District as a volunteer, probably about 12 years ago. I was going to school for public health, health promotion, and I was looking to get my feet wet in local health. And I didn't really know anybody, but I had looked at it kind of online. I was like, oh, Ledgelight, okay, that's my local health department. I met somebody on the beach who knew the person who was coordinating GASP. Her name is Michelle Hamilton. She lives in Pennsylvania now. And this woman told me to call her. She's like, just don't think about it, just call her. So my first experience in prevention was at a family night, which was a big event that GASP used to do for several years, where they would have a big family dinner and do prevention related activities. It would be a big family style meal, usually really yummy food, roasted chicken, the whole nine. And it would be at a local school, so it'd be a ton of families there. And I volunteered to be a conversation facilitator. Basically, I had some note cards. So that was my first foray into any of this. I had no idea anything about local health, really no idea about prevention. Calling on volunteers and reaching out to people was how I got my start, but also was something that the current coordinator at that time had to do to get somebody to get involved. So I had no idea that I was going to end up in prevention, substance use prevention, or anything like that. I, like many people in public health, was really interested in childhood obesity. I had written a lot of papers and was studying that pretty in depth. I thought I was going to be sort of initially, when I went to school, I was going to be in the fitness industry, and that didn't really work out. While this was all going on and I was trying to figure out what I wanted to do, I got invited to another family night. That's the following year, right? So after graduation, Michelle called me and she says, "Hey, come on down. We could use your help." And I said, okay. And so as soon as that happened, somebody quit at Ledgelight and they needed somebody to fill in. And wouldn't you know, it was the Childhood Obesity Prevention Program and some work in prevention. So that's kind of how everything happens for me. And this is kind of like a funny joke. So I always said I wanted to work in local health. Wouldn't that be convenient and nice? But I said, oh, I don't want to work there. And at the time, Ledgelight was in a little house on the side of the road, and we outgrew that. So within 5 months of starting to work there, we moved to a different building. So that was, very funny. And like I said, I promise I'm going somewhere with this. So my advice to you, based on my experience, would be if you're looking to engage people from the health sector, they may not be already established in a career, perhaps, right? So if you get a call from an eager student, take it, see what they want to do. A lot of people are willing to do what they need to get their feet wet. A lot of people don't have a lot of experience, especially if they're going to graduate school right out of college. They need experience. I've been at Ledgelight for over 10 years. I'm thrilled to be here. It's been a perfect fit for me. I get to put all of my knowledge and skills to use here. Now, beyond prevention, I get to work on other projects at Ledgelight. So over my time here, I've run our tobacco cessation program. I have been certified as a health inspector for food establishments. I don't really do that right now. But I've been part of lots of different grants, and Ledgelight has like 30 grants right now. So when I start talking about Ledgelight, I just want you to know that not all health departments do what Ledgelight does. There's lots of different health departments in the state of Connecticut that have different strengths and different focuses. Ledgelight has always been health education, community outreach centric, and we do a lot with grants. Not all health departments do that. So here I am, coordinator for GASP, and made the full circle from random volunteer to running the show. And like I said, not all health departments run like Ledgelight does. Some part-time districts have part-time directors, and they don't really, maybe they have one part-time health educator, and they're really focused on doing the other mandated things they have to do in public health. So a little bit more about Ledgelight and health departments. So we also function as a unit of government. We have a very strong grants management system, which helps me, of course, as a coalition coordinator, but also with writing strong grants and doing really well on our reporting and things like that. Great grant writing team. Over the time, we've had an epidemiologist. It's a great place to work. I'll just leave it there. We have access to data, leveraging partnerships and connections. It's very helpful sometimes. Some of you do, I do a little bit of academic detailing work, and those relationships from the health department have been very helpful there, in addition to GASP. We as a health department support a lot of coalitions. We have 2 in-house prevention coalitions, GASP and then Ledyard Prevention Coalition. So we run 2, and then we also have the overdose task force, and we have the collaborative, the Health Collaborative Improvement Collaborative of Southeastern Connecticut. So this is something that's, you know, Ledgely does a lot of, and it benefits me tremendously and the community. So we focus on primary prevention and harm reduction. GASP itself has been around since 1999, so we're over 20 years, 2 decades. And how we got started with GASP was kind of how it starts with a lot of coalitions, right? Somebody identified a problem, somebody got the agencies together to talk about it and to get things going. So in this case, I think at the time it was Groton Human Services and Ledgely. But we also have different, lots of partnerships in other towns and entities in the region, like CRAC for one thing, our BHAO, we work really closely with them. Some other places we also work closely with, and I will call on them for assistance. Like right now, I'm working with a lot of these people for my needs assessment, right? So Sound Community Services, mental health and addiction, Nat Child Care Plus, therapists. We've talked about all the different people that could be in the health sector. So these are all very important people that I have to call on now. So some of the things that I need that Ledgely provides help for, data, needs assessment, key informants. Sometimes when you're from the health department, people take you a little bit more seriously when you ask. I can't explain it. Campaign distribution. So the healthcare providers that I work with, agencies, facilities, waiting rooms. If I have materials, I do a lot with resource libraries. I need homes for things. Prevention rack cards. So I've worked with 3 physicians on that, local physicians, and they have lent their name and their likeness to that work. And that's been a very positive, popular thing. And then of course the SPIF, you know, some of the ones that I think jump out the most, I'll go right down to the cultural competence and the DEI work. We talked a little bit about social determinants of health and health disparities. Ledgely, since I've started working at Ledgely 10 years ago, has been, I would say, a leader in some of that work. Going back to the Health Equity Index and some of the Place Matters concepts, taking a look at some of those different areas within Groton and noting the differences and having focus groups and doing photo voice and things like that. I mean, just a big, lots of work there, and it continues. Supporting racism as a public health issue. You know, Ledgely is very vocal and supportive of those things. So my tips and recommendations, you know, GASP has been one of Ledgely's longest and most continuous programs that we're very thankful for. And I would say that their experience has lent itself well in other grant funded programs. We do a lot of different coalition work, not just in primary prevention for substance use. My tips would be make the phone call. Networking is really important. I told you how I got my job. It was literally just bringing it up to somebody at the beach. And I think that's important to just not be afraid to bother people or thinking you're bothering people. Or if you need something, just be really clear about your ask. And then, you know, celebrating your achievements and your successes. You got to be very outward about that. You know, I love a good press release. I enjoy letters to the editor, making sure that people know what you're doing, because people don't, they won't pay attention. And yeah, LLHD is a trusted partner with my coalition, but for other work that's being done in the community. So that's pretty much it. For many years, this quote by Margaret Mead was on our coalition agendas. I ran out of room, so I don't keep it on there anymore, but coalition work is really important, and it's people in public health know that. So that's it.
Carolyn, that was great. Thank you so much for sharing that experience. Some great tips in there for everyone. If anyone has any questions, feel free to unmute, and you can also put them in the chat box. And Carolyn, I'm wondering if you wouldn't mind sharing your email address in the chat box in case anybody has any follow-ups. If you wouldn't mind, we'll send it out after, but people may want to reach out and ask for some tips or guidance. Thank you so much. I'm going to go over to Mark, and Mark, you're going to introduce Gina. Yes.
Yes, greetings, everyone. Mark Nickel from TCAS, and our next speaker is Gina D'Angelo from the Department of Public Health. And so the Connecticut Department of Public Health exists to assure all of the conditions in which people can be healthy, to prevent disease, injury, and disability, and quite frankly, to promote health as a human right and a priority in the state of Connecticut. And we decided to ask someone from DPH, the Department of Public Health, to join us today for several reasons. One, DPH is continuing to strengthen its partnerships with the Connecticut Department of Mental Health and Addiction Services. And just an easy example, if you were to go on the CTDPH website, the landing page has changed the script campaign information and materials. So you can see how they're all aligning and supporting social norms campaigns and communications efforts. And there's also other activities that the two agencies are working on, such as overdose to action task forces. And we also know that when you're thinking of a state agency, we don't have county government. So the state agencies, when they're doing their work, they have to figure out how to interface with all the local towns and the local prevention councils and the prevention coalitions. And they also use the public health model. So we thought it would be a great conversation to have Gina, who's just been a champion, a lifelong champion of public health and also prevention, share with us how public health approaches its work and how we can understand how the work at the prevention coalition level and the community level all ties up to those bigger health outcomes, because we know that alcohol, tobacco, and other drugs all are contributing risk factors to chronic disease, to cancer, to higher likelihood of HIV, and so on. We just wanted to change the conversation space up a little bit, let Gina walk us through how DPH thinks about its work through some of its examples. So I turn the Zoom room over to Gina.
Thank you, Mark. I'll share my screen. Just want to make this. Don't know why I can't get rid of that there. The slideshow button is underneath that top screen there. I'm trying to get rid of it. And it won't let me get up there for some reason.
You want to go back out and do it before you come in, Gina? Like change the view?
Maybe I could do that. Hold on 1 second.
Sure.
There we go.
There you go.
Okay, so thank you, Mark, for that introduction, and thank you for the invite. I know that we're running close to the end of your time, but I'm Gina D'Angelo with the Department of Public Health, and I work in the HIV program, and was asked to share a little bit today about how we do our programming. We take an integrated and a collaborative approach to addressing HIV in the state of Connecticut. CTDPH is the lead agency for addressing HIV. In 2007, we actually integrated separate HIV prevention and care planning bodies and plans for the state into one. And integration and collaboration is very important. It maximizes your resources, both financial and human, but it also paves the way for us to do better and more comprehensive service delivery. We're getting ready to do kind of like an integration 2.0. We've realized recently in trying to end the HIV epidemic that we really can't just focus on HIV if that's going to happen. So we're going to be expanding our integrated plan to include sexually transmitted diseases, substance use disorder, and viral hepatitis. So we're going to use this Syndemic approach to end the HIV epidemic while trying to slow the spread of STDs, eliminate viral hepatitis, and also address substance use disorder. So what is a syndemic? Basically, it's just more than one health problem or epidemic that interact synergistically, and they create excess burden of disease. Most of our folks are dealing with more than one health condition that's confounding the others. So we started to look and start to connect the dots. If we look at HIV and hepatitis, we have a certain amount of co-infection where people have both. And though we have effective treatments to treat both hepatitis and HIV, having both can really impact the effectiveness of that treatment. We look at STDs and we see how biologically it's easier if you have an STD to get HIV and vice versa. And for those of you working with youth, I heard a lot about youth on your call today. That's where the majority of our STDs are in people ages 15 to 24. And HIV can be a precursor, or STDs can be a precursor to HIV. So that's something that I wanted to make sure was on your radar. And then we look at substance use disorder, and we know that that can increase risk for all communicable diseases, right? It can also impact and actually impede treatment, effective treatment, but it also leads to poorer health outcomes for all of our populations. The opioid epidemic is probably where we are most well tied, with the other epidemics doing a lot of drug user health work. So if we look at that strategic prevention framework that you're all familiar with, we use different language in the DPH and HIV world, but we do all of the same things, right? So I thought I'd give you an idea of how we implement the model. We do assessment, capacity, planning, implementation, and evaluation. When we're talking about assessment, we're really looking at our surveillance data to identify the populations that are at risk, the geographical hotspots where infection occurs, and then the trends in infection. So what does HIV look like in the state right now? Then we do our statewide needs assessment with people living with HIV. We do focus groups and listening sessions. We're also going to be doing that with people who are at high risk, or a prevention type needs assessment. And it's really to identify the needs that are out there in the community from the people who have the needs. Following that, we do a resource inventory where we look at all of the resources we have to meet those needs. And then the last step is doing a gap analysis and finding out, identifying unmet needs. So are we doing a good job in providing what our populations need? When it comes to capacity, we look at our HIV workforce in detail. We want to know who they are, what is their training like, what are their expertise. So we do training assessments to identify their capacity building and technical assistance needs. We also have established core competencies. What's the functional knowledge? What are the things that they need, the skills that they need to be able to do their work effectively? And then we're able to secure training through CDC or HRSA, or even through our own DPH staff to help people do a better job. We are currently working on a series of self-directed online learnings that hopefully will be out by the end of the year to further enhance the capacity of our providers. When it comes to planning, this is huge for us. DPH receives federal and state funding to provide HIV prevention and care services, but also to do planning. And we use a RFP process, which is an open competitive process, to fund services out in the community. All of our services and our resources are allocated using our surveillance data, and then also recommendations from our statewide planning group, which is the CHPC, or CHIPS we call it. So the CHPC is a really important piece of the work that we do. It's our statewide planning body with a very diverse membership of providers and consumers. And when I say that, our goal is to have 50% of the membership be people living with HIV. We also have people of other lived experience, such as substance use. So we work with the CHPC to develop a statewide integrated plan for how to provide services in the community. And our goal right now is really to engage the community and also collaborate with other partners, state agencies, community-based organizations, to create a data-driven plan to end the HIV epidemic. Our group meets the third Wednesday of every month from January to August, and is open to the public. And we've really been trying to reach out and get more people at the table to have discussions with us about how we can further this work together. So you're all welcome to attend. In terms of implementation, we do prevention and care services. We fund them in the community, and they're provided by lots of different organizations, from prevention and care providers to community-based organizations, community health centers, our hospitals, faith-based organizations, and also local health departments. So we contract with all of these folks to provide the services. In terms of evaluation, outcomes are very important. So our DPH surveillance program monitors the data for new infections, for outcomes, health outcomes. We can look at CD4 counts and viral loads to see if people are in care, staying in care, and remaining virally suppressed. Our DPH prevention and care programs also monitor data. So we have data managers that look at service utilization and program outcomes. And then, of course, because we're DPH, we do monitor the programs that we fund. So site visits, monthly calls, chart audits are all done to ensure process outcomes. We also have a quality performance measures team at the statewide planning group that monitors a certain set of indicators to see how close are we getting to ending the HIV epidemic and what else needs to be done. And then finally, we do an annual quality summit, which showcases some quality improvement projects, PDSAs, and best practices. Again, always trying to improve the services and the things that we're doing. There's a lot of special considerations, conversations we have at our statewide planning group that are very important, one of them being intersectionality. So looking at all the many social identities that people have and how they interact to shape how they view the world, but how others also view them. And recognizing that people have their own experiences of discrimination and oppression, and that there's a lot of stigma out there. And how does that impact the health outcomes that they have? So we do talk a lot about things like gender identity, sexual orientation, and race. We also look at social determinants of health, which were mentioned earlier, the conditions where people live, learn, work, and play, and how that impacts the risks that they take or their health outcomes. And I think the best example for the HIV world is housing. We really look at housing very in depth. We know that if people are not stably housed, then their health outcomes are usually much poorer. So looking at all these conditions, and then the lived experience of people is very important to us. So as I said, inviting people to come around the table who live with HIV or live with substance use disorder to share their experiences and to help us plan better. We also look at health disparities and health inequities. As we know, certain groups are more affected by HIV, STD, and substance use, and also viral hepatitis, and often they do not have the same access to services and to healthcare as other populations. So a lot of times when we look at our data, we'll slice it and look at it with a health disparities lens. Finally, stigma. Stigma is huge. It's attached to HIV, STD, substance use, and viral hepatitis. We know it can be internal or external, but that it often leads to harm and discrimination and causes people not to seek the help that they need, resulting in poor health outcomes. We did a lot of listening sessions a couple of years ago out in the community, and this is the one thing we heard over and over, is that stigma is pervasive, and we really need to figure out better ways of addressing it. Everything we do, I would say, is data-driven, and I think it's really important to remember that our data can tell a story and can really help us focus our efforts. One of our state epidemiologists years ago said, numbers are people. And it really helped me, because I don't like math and numbers, to think about how to look at the data that we have and allow it to really guide the work that we do. So we know certain populations are disproportionately impacted. All of our funding allocation for our services is data-driven, and population-based services are employed to the most vulnerable impacted populations. We also put those resources in the geographic areas with the greatest disease burden, and we use tailored evidence-based interventions to reach people with our services and programs. So this is just an example of one of the HIV data infographics that our surveillance department publishes. And I think if you wanted just in a nutshell to know what HIV looks like in the state of Connecticut, our newer cases are in much younger people, people of color, and men who have sex with men. The one thing I do want to point out here too, though, is that prevention works. And in 2002, 46% of all of our HIV cases were in people who injected drugs. In 2020, we got it down to 6%. I think that's largely in part to the syringe service programs we have and the drug user health programs that we do have. And so it's just an example of how we kind of track what's going on with HIV. We also know that there's disproportionate impact. So Black and African American people, while they only account for about 12% of Connecticut population, they represent 47% of new HIV diagnoses. So I think that it's important, to recognize that and to figure out how to tailor our messages to that community. CDC also published lifetime risk estimates of getting HIV, and for Black MSM, it was 1 in 2. For Black men, 1 in 20, and Black women, 1 in 48. Just to give you an idea, for white women, it's 1 in 880. So we're talking about huge disparities here in the populations that are impacted by HIV in particular, but we also see it with all of our other conditions. So population-based health is very important, and the goal is to keep everyone healthy. So the 4 pillars that we use in our work are prevent, diagnose, treat, and respond. And again, the populations that are most impacted that we're looking at are young MSM of color, African American, Black women and men, and then also transgender individuals have a greatly increased risk of HIV. Our high incident cities, Hartford, New Haven, Bridgeport, Waterbury, and Stamford, although we work and provide services statewide, we're really targeting those geographical locations. So what do we do? Well, it's time to break the silos. I think we need an all hands on deck approach. So, building partnerships better serves clients. A lot of our organizations and a lot of our groups reach the same vulnerable populations. So I think it's really important for us to build relationships within and outside organizations so that we can make those active referrals and linkages. And if nothing else, at least that we're sharing information and data. The all hands on deck approach has really worked with the opioid epidemic. We've seen that. In particular, when we had the mass overdoses on the New Haven Green, a lot of agencies, organizations came together. We were able to get Narcan down there quickly from DPH. The OD2A grant that some of you might be familiar with, if you're on those calls, DEMIS is there, DCP is there, Department of Public Health is there, and then a lot of you coalition folks are there. So really having this all hands on deck approach to providing services is something that we're really trying to expand and do more of. So I think, building those bridges with other groups, developing an understanding of all the conditions impacting our clients, not just the thing that we're focused on. So not just HIV, not just substance use, but how do all of these things impact them? And then developing an understanding of the programs and services that are available out there in the area so that we can build networks and contacts and provide those seamless referrals to the people that we serve. So lastly, just to give you an idea of what we do in HIV prevention, we do have that data surveillance program that can provide data to our public health partners, medical community, the general public, and they're really tracking, newly diagnosed cases, people living with HIV, and monitoring trends. We have a healthcare and support services program that is a federal grant that actually provides core medical and support services for people living with HIV. So if people can't afford care, we do have programs that can help them get access to care. And then we have a KDAP program. How many times have I heard, oh, people can't afford those AIDS medications? Well, they can get them. We provide eligible low-income residents with medications and also health insurance premium assistance coverage. There's also often they can get co-pays covered as well. Up next is HIV prevention. This is the crux of how we are trying to get out there and diagnose and prevent HIV. We do HIV testing in the community through our outreach testing and linkage. So this is actually outreach-based testing with a rapid test that takes 20 minutes out in the field. And then those folks get some brief counseling and are linked to other services. We also do routine testing services in our clinical settings, hospitals, community health centers. That can be a rapid test or a conventional blood draw, but it's more a routine part of healthcare. And then those folks are also linked to prevention and care services. During COVID, we started an in-home test kit initiative with 16 of our DPH funded sites sending HIV kits to people's homes or whatever address they provide us with, and providing them TA to perform a test at home. To date, we've, January to June 2021, we distributed 421 kits. PrEP is probably the biggest game changer out there. If you haven't heard of PrEP, it's a pill that's taken once a day. It's an HIV medication that can prevent HIV. Game changer for people. If you have a couple, one of them has HIV and the partner does not, can actually prevent HIV transmission. So we have a PrEP coordinator and PrEP navigators out there who provide education on what PrEP is, do a risk assessment and eligibility screen, and then can help people access PrEP through a medical provider and also get financial assistance. Linkage and follow-up are very important for people who want PrEP, but PrEP is a huge game changer in the world of HIV prevention. Finally, we have effective behavioral interventions. These are individual or group or community level groups. These are tailored for certain populations. So the picture you see here is one of our empowerment groups. It's a group for young MSM, men who have sex with men, and they do outreach activities. They do effective prevention messaging, but they also have fun too. They do a lot of fun activities. We also do these programs for African American and Black heterosexual men and women and people living with HIV, and they're funded all over the state. Finally, our DPH programs also have drug user health programs, which are typically our syringe service programs that collect and distribute clean syringes. They also do overdose prevention, handing out naloxone, harm reduction, wound care, and they can facilitate getting people into medical care or substance use disorder treatment if that's what they're looking for. And they also screen for HIV, HCV, and make referrals for STD screening as well. So these are our boots on the ground programs. What you see there in the picture is a rover. It's kind of like a traveling prevention kit that many of our agencies are using. Finally, we have a partner services program, and these are disease intervention specialists who can do partner notification and testing. If someone is HIV positive, then they can give contact information to our DIS, and they will help notify people that they have been exposed and then facilitate testing. This can be done anonymously or with the person with assistance. Last but not least is our community distribution center, where we warehouse condoms and print materials. This is something that our funded agencies can access, but it is also open to the public. So there's a website there, www.harmreduction.ct.org, where you could get some of these resources for your programs if you were interested. So I went through that really quickly, and that was a lot of information, but I think, you know, for us, we really value community engagement and building partnerships and collaborations within and across agencies and organizations. And I think anything that we can do to collaborate just helps our clients in the long run. So if anybody has any questions, I will drop my email into the chat. Thank you.
Wow, awesome. Thank you so much, Gina. That was an incredible presentation. I know I certainly learned a lot. Does anyone have any comments, observations, thoughts on what Gina shared. I think that it was just nice to learn about a state agency and how they're looking at prevention effort through a somewhat different lens than we sometimes talk about in the substance prevention world, and just how it's very kind of similar in terms of the modeling and the aspects that they do as well. So does anyone have any questions or thoughts? That was great.
I have just one thought, and I think we in substance misuse prevention is like a step behind, is really identifying who the priority populations are. We still tend to look at kids as, you know, the whole group of kids. And I think that's sort of one of the next steps for us in prevention, is to look at who are some of the priority populations who need more than the basic foundation level of prevention. You know, what's the next step? So that's a good takeaway for me, Gina. Thank you. You know, when you shared who the populations were, how you identify them, how you work with them. So thank you.
You're welcome.
I liked this notion of breaking down the silos. And I think one of the ideas around the 12 sector series was to really be able to look at breaking down those silos and looking at all of these key community partners as already doing prevention work, and how do we highlight the work that all of these different sectors are doing already and bring them to the table in our coalitions to benefit from them, and how we can benefit them in return. So thank you so much for that, Gina. I really appreciate it. It was great.
Hey, Jen, could I interrupt? Mark, I think, had his hand raised.
Oh, sorry. Sure.
Hi, one of the earlier interactive polls had to do with the extent to which community prevention coalitions are engaging pharmacists. So could Gina tell us a little bit about what, if anything, CTDPH is doing around?
Sure. We're fortunate to have a pharmacist on staff in our healthcare and support services program for HIV. And that's because we run that Connecticut AIDS Drug Assistance Program, where we're able to get people onto medications who need them. And so we work a lot with the pharmacists to make sure that they're prescribing current regimens and not outdated medications. And so we've done a lot. We've also did a number of years back, we did a survey of pharmacists to find out if they are actually selling clean needles to people without a prescription, because there is a state law that people can purchase 10, I think it's a limit of 10 syringes at your local pharmacies. And it was really interesting, some of the information that we found out. You know, they're all over the map. There's pharmacists that really understand public health and allow people to come in and buy clean syringes. And then there's others that are like, no, we had too big of a problem in the parking lot with drug users coming here to buy needles, and they just won't sell them, right? And it really is up to them whether or not they will do that. But, you know, we've engaged our pharmacists in a number of ways, whether it's through providing medications for people living with HIV, or looking at this whole, you know, what is their role in helping us on the drug user health front.
I have another question to do with what, if anything, or your experience as a state agency has been to influence like health, sexual health education or health education in schools, in the education system.
Yeah, so you know, I think it's been an uphill battle. You know, we had a long-standing, really good relationship with the State Department of Education, and so we've worked with them on trainings, but you know, with local control being in place, and it's very difficult. While we have a very comprehensive curriculum framework, not every school district is doing the same thing or following on that path. So I think it's been tough. I don't think that we've made as much headway as we need to there, and that we need to keep strengthening partnerships and trying to make better inroads in terms of comprehensive sex education. But we do have that framework that's very, you know, in my eyes, is very progressive. And so that's, at least there is the groundwork there, but it's very difficult to try to get these separate school districts to all kind of follow it in the same way. There's not really a system in place for that.
Okay. All right, moving on to our next section. Just really briefly, we're going to talk about sector levels of involvement. Again, a heavy slide you can read on your own time, but really when we're talking about collaborations and some of the things that we've been talking about today and breaking down silos, you know, those sector levels of involvement go from no involvement to collaboration. So no involvement is you've got separate entities working on separate policies, separate strategies, you know, people are kind of doing their own thing. Networking, you might be, you know, talking to each other, or maybe sharing a little bit of information, but not really working together in that sense. Cooperation, you start to see a little bit more collaboration in this level once where you're kind of supporting each other. Maybe you're co-sponsoring some trainings. I'll support you, you support me. Coordination is where we are going to start event planning together. We might serve on community boards together or implement some programs and services together. And collaboration is where you really are taking your agreement to work together to a more formal level. Doesn't necessarily mean you have a formal agreement, but sometimes you do. And we are looking at common data collection, or joint fundraising. We might be pooling our fiscal or human resources, and really just understanding that we're kind of all working towards the same goals here and working together on those efforts. So just a quick next poll, we're going to ask you guys, what level of involvement in your place of work or your coalition level of engagement with the health sector would you say is at no involvement, networking, cooperation, coordination, or collaboration? Okay. So I hope everyone can see the results. And it looks like people are kind of, all 5 levels are present here today. So, you know, it looks like a majority of people are in the cooperation stage. So talking to each other, maybe starting to work together, but we're really hopeful in asking this question and listening to Carolyn and listening to Gina today, that you've been able to identify some ways that you might be able to break down some of those silos or reach out. And as Carolyn said, make those calls. Thanks so much. Quickly, just going over some typical barriers to engagement across sectors and in with the health sector as well that we see. We've gone over this before in other series, but just as a reminder, sometimes, you know, maybe the health representatives in your area just don't perceive your organizations and theirs to match in terms of their mission or goals. Maybe there could be sometimes some challenged local history, just availability of members of the health sector in your community to actively participate in your activities and strategies. Some minimal organization on your part to be able to engage the sector, to make those calls, to have those meetings, to bring them to the table, and just recruiting and sustaining their participation over time, and having high turnover rates. So quick poll question, next one is, what are some of the barriers that you've experienced where you are, if any, to engaging the health sector? So sometimes when we identify maybe what our barriers might be, we can start working at addressing how we may be able to overcome them. Okay. So here we go. This is probably interesting for everyone to see the results on this, but availability of the members of the health sector to actively participate seems to be our #1 challenge. That might be around meeting times or just during the workday and just having that time available to join you. Capacity to engage them, recruiting, turnover. So yeah, we see these are across sectors as well. So these are not uncommon. No one's alone in these challenges. It's truly just about how we acknowledge them and understand them, and then hopefully make efforts to overcome them. So thank you for sharing. So on this slide, we give some ideas on overcoming some of those barriers. So whether you're just beginning to reach out and you're not really engaged in the health sector at all, or whether you are in a limited capacity and would like to increase that engagement with them, we give you a bunch of ideas here. Hopefully 1 or 2 will stick or work for your community. And again, it's just, reaching out, making those calls, like Carolyn said, identifying who in your community from this sector may be able to attend or come speak at a presentation or a meeting for like 10 minutes, highlighting some of the organizations in your community. Say, hey, we're having a meeting next month. We'd love to highlight your organization. Do you want to come and talk to us about 10 minutes or so? Is an idea that I see a lot. Just leveraging the health sector's capacity, their programming, making sure you know what they're offering and doing, and sharing that with the coalition and your community as a whole. Really just keeping them abreast of your data, your information, things that you're talking about, what you've been learned through your data collection, your needs assessment, so they're aware of what you're doing. And then just maintaining those relationships, of course, and promoting and scaling the healthy development activities that they're already engaged in and doing. And then just really asking for professional development. If people need more trainings and PD to be conducted by health representatives, just like we had today. I feel like I had a little mini PD today during this training. So just understanding the breadth of the health sector and the prevention work that we all do. So poll question number 5, in looking at some of these ideas, maybe pick 1 or 2 here that you would think that you might be able to work on going forward after today. Okay. So it looks like across the board, some inviting health sector representatives to attend meetings is a big one. Asking for professional development, some trainings, that's a great idea. Leveraging their programming. So hopefully some of these will be taken home with you today or back to your work to think about how we can engage and maybe overcome some of those barriers. So thanks for answering, everyone. I appreciate it. Moving on. So now we're going to be moving into our resources section of today and wrapping up. So we always include this slide in our presentations around our RBHAOs, our Regional Behavioral Health Action Organizations. For those who may not be aware, Connecticut has 5 RBHAOs, and every town belongs to one of them. So when you get this presentation, you can literally just click on either one, the one that your town may belong to, where you can find more information from the RBHAOs on some of the things that are going on in your area of the state. I do provide you here with a little levels of collaborations tool. If you'd like to take it to a leadership meeting or a coalition meeting, you can just print it out to see where your members feel that you are operating at in terms of your engagement with the health sector or any of the other sectors that you partner with. Again, just the SAMHSA chart here that we mentioned earlier in the presentation, which provides you with several ideas in each step of the SPF for opportunities to integrate cultural competency into your work. Same with sustainability in each step, just give you some more ideas there. So this slide I put together, and I'm really hoping that this will be helpful for you guys. I provided links on this slide that give you links to the Connecticut DPH Prevention and Health Promotion Division, DMIS, the Connecticut Data Collaborative. They have town profiles. So for every town, there is a profile that you can get some good information on. So whatever town you might live in or work in, you can get some data there. The state recently released Connecticut Town Equity Reports. There's also health information in those reports by town. So if you're working on your needs assessment or just want to get some updated information on disparities, you might be able to look in theirs for your towns. There's also the regional priority reports on substances. Again, a link to the RBHAOs, your local prevention councils, and of course, TTAS coalitions, tools, and resources on our own website as well. So hoping those will be helpful for you guys. Just including a slide here for those in terms of our breadth of professional trainings and tools that T-Task offers. So at your leisure, you can look on here. That's something that might be interesting for your coalition or for you that we can offer or provide. And then just finally to wrap up, a link to our website where you can find more the resources that we were mentioning previously. Shay is going to put an evaluation link into the chat box, and I would really appreciate, it's about 5 questions, will take maybe 10 seconds or so. If you wouldn't mind just filling that out, as we're always looking to improve all of the trainings that we're doing. So we would love to get your feedback today if you wouldn't mind filling that out. I've included a few save the dates. We've got Prevention 101, Fundamentals of the Prevention Field coming up. This was a big ask by our LPCs, our local prevention councils around the state, to provide a general Prevention 101 training. So that's coming up on October 12th. We also have a meeting management for prevention coalitions and local prevention councils on October 19th, where you get some ideas around running meetings and organizing meetings. And then also our certified prevention specialist exam prep session is coming up on October 27th. So all those registrations are up and available on our website if you'd like to register for any of those. A link to our YouTube channel, and then finally my email address. So that is it. So I'm going to stop screen share, and I'm just going to thank everyone for being here today. If there's any last minute questions or comments, happy to hear them now. Otherwise, I just want to thank our guest speakers so much, Carolyn and Gina, for coming today and sharing everything that you did, and for all of our attendees. We hope that you'll walk away with some good information and insights today from our networking opportunities and the information that we provided. So if there's nothing else, then we can wrap up a little bit early. Anyone have any last comments? If not, have a wonderful day.